Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we start a new mini-series, this time again coming back to classical hematology, and we're talking all about immune thrombocytopenic purpura, or ITP.
Really excited to get back into the swing of classical hematology. We've got a lot of questions from our listeners about ITP management, and we're going to break everything down for you, give you a practical framework, and also maybe challenge some of the current new guidelines that are coming out in 2025 about how to approach upfront therapy.
Yeah, and it's something we see all the time. It's a problem you're going to face in practice, and I'm glad that we're finally kind of consolidating our thoughts on it.
Yeah, that sounds good, guys. So let's roll that show. All right, everybody, how we doing?
I'm just making it through. So having the newborn really has messed up our recording schedules. Sorry, listeners, we're doing our best, but my life's been a little bit hairy these days. Little guy is sometimes sleeping, sometimes not. Love him, but, makes all this a little bit challenging.
Yeah, I'll bet. It's definitely, I'm happy you're able to make it tonight.
Meanwhile, I'm just out here living my dink life. So I'm going to, continue having as much fun as I can before I have to do what you got to do, Vivek.
What about Love is Blind? You up to date?
Oh, definitely up to date. I've watched.
Oh, it's so good.
It's so good. It's so good. I don't know when this episode is going to come out, so I don't want to give anything away. But guys, if you haven't watched this season, the Ohio season, go watch it.
And Bridgerton. The season of Bridgerton, fire.
Phenomenal.
Way better than the last one.
This is also what we've been doing while Vivek has been taking pseudo-paternity leave from Merlot University.
Yeah, Logan and I actually just went out the other night and saw Nirvana, the band, the show, the movie, which highly recommend.
So many good recs, guys. This is why we need time off so that we can do fun things like this instead. But, we've definitely talked about this topic of ITP before. We talked about this in one of our initial episodes. We also talked about this as a hematologic emergency, and we definitely discussed initial management, but we never really got into the nitty-gritty. So really, I'm excited today to talk about what we do beyond just giving somebody steroids and IVIG. We're going to go through a framework for approaching some of the data, how we think about more nuanced cases, and hopefully this sets you guys up for success. And this will be just the first part of this discussion. So Vivek, do you want to kick us off with a case?
Yeah, so we have a 23-year-old female with no past medical history who comes to the emergency department with several days of spontaneous bruising on her arms and legs, as well as a new rash on her lower extremities. On a review of systems, she also endorses an episode of epistaxis and some increased gum bleeding while brushing during this time. She denies any recent infections or new medications. She has no family history of bleeding disorders. Vital signs are normal. Her exam is notable for multiple ecchymoses on her arms and legs, as well as petechiae on her shins. A CBC and coags were obtained. Her workup was notable for an isolated thrombocytopenia with a platelet count of 12. Notably, her prior baseline was 189 on an outpatient CBC done 2 years prior to that. Coag studies were normal. A stat hematology consult was placed, so this happens to us all the time. Where do we go from here? What's the initial workup for a patient with newly diagnosed thrombocytopenia?
So definitely check out our thorough overview of thrombocytopenia workup in episode 9, so way back in the day. And just remember that it's very important to give a broad workup whenever you're faced with thrombocytopenia. There are a lot of urgent, immediately dangerous causes for this. But we like to analogize our approach to this like you would with working up an AKI, a kidney injury, looking at sort of pre-platelet, intraplatelet, and post-platelet, or pre-marrow, intramarrow, and post-marrow. So for pre-marrow, so like good marrow, bad world, we're thinking about infections, medications, toxins, that sort of thing. Things like HIV, hepatitis C, these are common viral precipitants of ITP. And then infections that might more affect the bone marrow, things like your Epstein-Barr virus, cytomegalovirus, histoplasmosis, some of these endemic fungi that can get in the marrow and cause trouble. As far as intramarrow processes, this is things like primary bone marrow failure, aplastic anemia, again, more likely to be pancytopenia in that case, and so a little bit less common for that to just be thrombocytopenia. Then our post-marrow, so things that are destroying the platelets or excessively consuming them. This is where the real dangerous, immediately dangerous stuff is going to be. Things like DIC, TTP, and then ITP. Also, of course, we'll include platelet clumping here. So always look at the smear. You want to see if there's some sort of microangiopathic process that's chewing out the platelets. You want to look for those schistocytes. And then you also want to see if you're actually dealing with true thrombocytopenia or pseudo-thrombocytopenia in the case of platelet clumping. But, our workup, like I said, starts with the smear. Make sure you're looking at that every single time with thrombocytopenia. You can order a citrated platelet count also if you're worried about platelet clumping to see if there's a way to break up any of those clumps that you might have observed on your smear. You also always want to get a repeat CBC sort of in parallel as you're starting this workup. Make sure that we aren't looking at an artifact here. You can check your coags as well, along with the fibrinogen, looking into could this be DIC? And you can add a D-dimer to that if you're worried that this might be more of a chronic DIC picture where your fibrinogen may still be normal or even elevated. Check the HIV serologies, check your hepatitis serologies. And then you can consider looking into haptoglobin LDH, sort of that, again, thinking about microangiopathy or concurrent autoimmune hemolytic anemia, something like a Evans syndrome. Just keep in mind that in liver disease, where you can have splenic sequestration and some thrombocytopenia with that, there may be some confounders on the markers for hemolysis, including both haptoglobin and LDH. So again, check out episode 9 for that thorough overview of how to work up thrombocytopenia, but that's kind of an overview of what we want to do.
Yeah, I think that's great, and really highlighting that smear is critical. You can look for schistocytes, fragmented red blood cells, to rule out something scary when you're thinking about a TTP, a thrombotic microangiopathy, so I think that's great. Her workup was most notable for this just isolated thrombocytopenia. Everything else was really unremarkable. The peripheral smear just showed a marked decrease in platelets, and there was really only one platelet per high-power field. We didn't see any fragmented red cells, nothing that rang our alarm bells for a thrombotic microangiopathy or a TTP. And recall our prior episodes on this from our podcast. So, Ronak, when do we start invoking this diagnosis of immune thrombocytopenic purpura or ITP? It's always easy if the platelets are less than 5 and you gave a unit of platelets, but, in general, can you just walk us through a framework when to think about this?
Absolutely. I know Dan said we see this all the time, which in reality we do, but I said this before, like when I was in medical school, I thought that no one ever got ITP. That's what it felt like it sounded like when we were learning about this. And then I got to residency and fellowship. And now as an attending, I feel like we see this all the time. But, we really want to consider ITP as a high likelihood in patients who present with really acute onset thrombocytopenia. And this is often with severe thrombocytopenia in the neighborhood of platelets less than 20. And this is often, and actually it should be, on your list of possibilities, especially when the other cell lines are not abnormal. So that being said, though, the formal definition of ITP is that it's found and diagnosed with a platelet count of less than 100 without any identifiable cause. So truly still a diagnosis of exclusion. And as we'll discuss, I'm sure, we typically just observe these patients until their platelets drop into a dangerous range. And that's around, usually in most patients, that's around a platelet count less than 20. In general, most patients are going to be asymptomatic. Others may start presenting at first with mucosal bleeding or petechiae, or they'll have easy bruising, similar to the patient that Vivek presented in our case here. In rare cases, you can have patients with really severe bleeding, which certainly is a challenging situation, and we'll come back to that in a little bit. In general, though, we also want to keep the age distribution in mind when we're adding ITP to the differential. It does seem to follow a bimodal distribution where patients in their 20s and 30s can get ITP with a slight female predominance. And then there are patients that are older than 60 where the predominance between males and females is roughly equal. And at the end of the day, it is believed that ITP is an autoimmune condition. So the overall mechanism, however, is not well understood. At the heart of it, we know that there's a presence of these antibody-coated platelets that are being destroyed by the spleen, the liver, or both. And antibodies can also induce complement activation, and therefore they promote desylation and lead to megakaryocyte destruction as well. Interestingly, up to 50% of patients will not have platelet-directed antibodies in circulation. So although that test is sometimes orderable on a panel, it doesn't really have a role in how we work this up. So we don't recommend sending that. But as you can see, more patients than we may realize truly have ITP, but it really becomes something that we really think about, especially when we're dealing with severe thrombocytopenia.
Yeah, and there certainly is like a phenotype when you see this, right? Like those platelets less than 5 in isolation, that patient otherwise looks fine. They may have some petechiae, may have a nosebleed or something. But, it's like this profound thrombocytopenia with bruising, bleeding, a little bit out of proportion to like not at the level you would expect for that degree of thrombocytopenia. But essentially, it's a diagnosis of exclusion. You're right. We need to rule out everything else, but then once you get there, that's what you got. And so before we get into the nuances of treatment, can we define some of the key terms regarding duration of ITP and the response criteria? This is really something that you see a lot if you're looking at the literature related to ITP. And so it's important to kind of standardize those definitions that you're going to come across.
So I can talk a little about the stage of disease, and I want to really point out that this is a diagnosis of exclusion and that you should always consider secondary ITP related to another lymphoproliferative disorder. Sometimes it's from a lymphoma. So just doing a good clinical exam as well and really ascertaining whether the patient has B symptoms. It's uncommon, but you don't want to miss that in a patient with ITP. Often those are the patients who have ITP that's just not responding to therapy after therapy after therapy. And then you find out they had an underlying malignancy and this was secondary ITP. So that's a really important point about that diagnosis. So when we think about the stages of the disease, newly diagnosed ITP is a duration of less than 3 months. Persistent ITP is 3 to 12 months. Chronic ITP is when patients have this diagnosis for over a year. And when we look at remission criteria, and this is important when you look at studies, what is a complete response versus a partial response? A complete response to therapy is defined by a platelet count greater than 100 at 1 year. So that's sustained high platelets. And we know that for some of our patients with ITP, if they hang out around the 50s, that's okay for some of those chronic ITP patients that we have, that you don't need a normal platelet count for all of these patients. So how do we think about response? We think about patients with corticosteroid-dependent response, and that's ongoing need for continuous prednisone of greater than 5 milligrams per day or a prednisone equivalent, or frequent courses of corticosteroids to maintain a platelet count greater than 30 and or to avoid bleeding. A durable response is a platelet count greater than 30 and at least doubling of the baseline count at 6 months. Early response is a platelet count greater than 30 and at least doubling at baseline at 1 week. And initial response is that platelet count greater than 30 and at least doubling from their baseline at 1 month. So basically, the platelet count of 30 is a response. And we say that because that's when we're not as worried about spontaneous bleeding. Yeah, maybe that patient can't get a intracranial surgery, and there are things we can do to potentially get those patients there, but that's a safe platelet count for a patient to be moving on in life. And that's why we say, hey, that's still a good response. And as you'll see, ITP, and as we'll talk about some of these cases, particularly in our next episode, you'll see that this can be a very challenging patient population to treat when these cases get a little refractory. So we don't need to be perfect. Our platelet numbers don't need to be perfect. I think that's really important. So platelet greater than 30 is a good goal to get to. And remember, if you're like at 50, you're really happy for a lot of these patients with chronic ITP. So at the start of the discussion today, we mentioned that ITP is technically defined as a platelet count less than 100 without an otherwise identifiable cause. So when do we start thinking about treatment and hospital admission?
So in patients with platelets that are less than 100 but still greater than 30, and they don't have any evidence of bleeding or anything like that you're worried about, it's generally okay to observe them in the outpatient setting. You do want to monitor them closely and want to get lab checks on a fairly regular basis. And you have to understand, if they're on a medication that makes their risk of bleeding worse, so say they're on an aspirin chronically for a history of stroke or something like that, that is something that you may need to pay a little bit more attention to or actually go ahead with treatment at that point. But by and large, patients who are kind of sitting in that under 100 but above 30 range might be okay to just keep a close eye on them with repeat lab checks. For folks who are below 30,000, but still greater than that 10 to 20 kind of danger zone, we would usually want to start some kind of treatment in the outpatient setting. And if they're steroid responsive or have been in the past, then oftentimes that means a course of steroids. In patients with newly diagnosed ITP and platelets less than 20, we want them in the hospital by and large, because you just want to make sure that they're getting the care they need and that you kind of have figured out what they're going to respond to. In folks with that more chronic disease, this is more of a case-by-case basis. So if somebody has been through this a lot, they're responsive to steroids every time, and they're sitting, at platelet count of 17, okay, maybe we can actually manage them outpatient. It's all about sort of your relationship with that patient and your knowledge of their history at that point. At the end of the day, in terms of recommending treatment, there are three main reasons that we go forward with it. One is to reduce that bleeding risk. This seems fairly obvious. Folks at the highest risk of bleeding are those who are below that 30,000 threshold and who have other risk factors, chronically bleeding angiodysplastic lesions in their gut, for example, or a history of spontaneous intracranial bleeding or frequent falls, something that's going to put them at risk of a more serious situation at that low platelet count. We also will be trying to get patients into a remission. Maybe we can give them a long period of time, a durable period where they're not experiencing these dips in their platelet count. And that goes right into also trying to improve their quality of life. A lot of folks with ITP report sort of severe fatigue associated with their low platelets. Not quite clear why this is the case. It might be something about the immune activity, sort of the energy needed to produce extra platelets, who knows? But it is, people report a pretty poor quality of life when they're flaring. And it's possible that addressing ITP and also just kind of unburdening folks with the knowledge their platelets are low might improve these symptoms as well. So we'll link to an article about how I treat primary ITP that lists a lot of these issues, but that's sort of what I think about in terms of treatment.
All right, so we have our patient getting back to our case. Her platelet count's 12. Ronak, you're saying, hey, you got the call, and you're saying, definitely admit her. What are you going to do for this patient?
Yeah. So the backbone of treatment, as we've been alluding to, is corticosteroids. And, with steroids, the reason we do that is because, as we said, it's an autoimmune condition. And also, these platelets are really low, right? We want to do something that we know is going to increase their platelet counts quickly so that we get them out of that danger zone quickly. And also, so with that in mind, corticosteroids have an efficacy that we can see in about 1 to 2 weeks. Most of the time, it'll be within a week, so usually a few days. We typically start with dexamethasone, 40 milligrams, so high dose steroids for 4 days. You can use oral or IV. They have about equal efficacy. And if for some reason the patient can't get dexamethasone, another alternative is to use prednisone. And the dose of prednisone that's recommended is anywhere from 0.5 to 2 milligrams per kilogram per day, although I think most people probably start with 1 mg per kg per day. And then this is continued for 1 to 2 weeks, after which patients are typically tapered. In general, about 60 to 80% of patients will respond to steroids alone. However, a sustained response after steroid discontinuation will be seen in only about 30 to 50% of patients, so it may not be something long-term. It's really important that steroids, including the taper, are not continued for more than 6 weeks. So you're really trying to get these patients off of their steroids in that 6-week time course. And that's because of all the side effects that we already know about that can be caused by long-term use of high-dose steroids. So, again, you want to hit them up front real hard with the dose of steroids, and then you want to start tapering that steroid course down pretty rapidly, at least over a 6-month period. Of course, checking labs along the way, making sure you're doing this safely. In many cases, we'll often add something like IVIG at 1 gram per kilogram for 2 days. And this is especially important for patients that have really low platelet counts, less than 10. Unlike steroids, which can take up to a week or two to take effect, like I mentioned, IVIG really has an onset of action of 1 to 4 days. But the effects are transient. So again, you're trying to quickly get their platelets up while you're doing this in conjunction with steroids so that the steroids can sort of take over thereafter. And then that way we can hopefully sustain more of a response. As a practical note, if you are going to be treating with IVIG, please always make sure that you're checking hepatitis B serologies beforehand. And this is because patients that get IVIG and then thereafter we're like, oh no, we need to maybe give them rituximab, which can cause hepatitis B reactivation. You can't tell if somebody's positive on their titer because of IVIG that they just got, or where they truly have hepatitis B, had it in the past, in which case they're going to need prophylactic therapy. So always just check Hep B up front if you think that there's going to be indication for treatment beyond just steroids. Platelet transfusions don't really work. There are certainly nuanced situations where somebody may need platelets because they're having a life-threatening bleed or something like that. But in general, we try to avoid platelet transfusions. So to summarize, you're going to hit them with either dexamethasone or prednisone, plus minus IVIG depending on how low their platelets go, and try to avoid platelet transfusions if possible.
I think this is really, really important, and we're going to link it to our show notes. There's a randomized study that looked at patients who got high-dose prednisone versus pulse-dose dexamethasone. And why we highlight that, it really is reinforcing this idea that a pulse dose of dexamethasone is 4 days of steroids rather than a long taper of steroids. And you're getting the actually increased initial response rates, though your durable responses are likely the same between the two groups. And I think that's really, really important. So when you pulse dose a patient with dexamethasone, the median time to response in this randomized study was 3 days with a range of 1 to 9 days. So you're expecting this to occur within about 3 days. And I think that's really important. So if you're not hitting that milestone, that makes you a little bit more concerned, and it makes you think that, one, is there another cause? Is this secondary ITP to something else? Or two, maybe sometimes you need to switch the patient to a more prolonged taper of prednisone. There are all these nuances that we can talk about in future episodes. But just for everybody to know, there's the randomized study. The sustained response was the same between the two groups, but there was an increased initial response rate favoring the pulse dose dexamethasone group, and there's no difference in outcomes between the two arms.
Yeah, and we'll make sure we have a link to that study. It was from 2016 in Blood. And this also gets into an area where there's sort of been some recent developments. There was a guideline released at ASH 2025 that it's still provisional and it's sort of based on low quality of evidence, but they're starting to think about incorporating things that we considered second-line therapies up front with those steroids. And we'll talk about some of the second-line therapies in a little bit, but suffice to say, this is sort of an area that's in flux, and we may end up recommending a little bit more on the upfront side when patients are initially diagnosed and treated. Ultimately, as that study in Blood showed, about 25% of folks will have a sustained response with steroids alone. And that's not an insignificant population, right? It's a minority of folks, but it's not an insignificant population. So I still am in the practice of treating folks with steroids alone, plus minus IVIG if I need to get a quicker response, and then just negotiating with them or discussing with them. Look, if you're willing to get your labs checked very frequently, I think steroids alone is very reasonable. If not, or if you have other concerns or were worried about following up, I think incorporating one of those additional therapies to try and increase the risk of a sustained response is important.
So Dan, with that in mind then, in this patient that's sitting in front of us, the question is inevitably going to come up. The hospitalist team is going to call you and say, when can we safely discharge this patient? So what are you going to tell them?
Yeah, and so this is just like everything we're dealing with here. It's not going to be one size fits all. Ultimately, you need to consider their risk factors. You're trying to minimize risk of significant bleeding related to their ITP after discharge. But, you want to kind of take into effect all their comorbid conditions, any medications they might be on that increase their risk, the trajectory, the rate at which their platelets responded. All this is important. As far as the ASH guidelines go, we want to see platelets reliably over 20,000. I technically, again, because 30 is kind of our magical threshold for treating patients inpatient versus outpatient, a lot of times we're just observing 30,000 is kind of my threshold. So what I tell the fellows that I'm working with, what I tell the hospitalists that I'm working with, I want to see that patient's platelet count greater than 30,000 and rising. And so, if they came in less than 5, the next day their platelet count's 12, and the day after it's 57, awesome. Go on, get out of here. If it's sort of limping along and then by the 4th or 5th day it barely gets above 30, I might want to talk about seeing at least one more day of labs to make sure that's not just going to drop right back off a cliff.
Yeah, and I think it's really important that you mentioned this is not one size fits all when we think about these patients. And just to circle back on the frontline treatment, and there's provisional ASH 2025 guidelines, and these will, maybe come out in the future, that we may consider at a low quality of evidence adding rituximab to steroids, so that anti-CD20 monoclonal antibody rituximab, thinking that, well, maybe that's going to deplete the B cells, is used in the second line, which we'll talk about in the next episode. But that combination of therapy, we'll summarize that in a table in our show notes that Dan the Man has created for everybody, just so you can see that there's conflicting data here. And when you look at longer term follow-up in these studies, not just the 1 month, the 6-month mark, but at the 1 year mark, there doesn't seem that much of a difference when you incorporate rituximab in the frontline setting. We also worry about that increased toxicity, so just something to keep in mind. So Ronak, do you want to take us home with this first episode as we kind of wrap up frontline management, and then our next episode we can talk about second line and beyond therapies for these patients?
Yeah, absolutely. So once again, in a patient that comes in with isolated thrombocytopenia, you want to go through that algorithm that we outlined with the pre, intra, and post-marrow processes, and of course, rule out other possibilities of isolated thrombocytopenia. After you've done a thorough history and physical on your patient and done the laboratory evaluation and most importantly looked at a smear and you are suspicious of this patient has ITP, the front line in management is going to be steroids, either dexamethasone or prednisone up front, because again, this is an autoimmune driven process. And in addition, in patients that have really severe platelet counts less than 10 and or have evidence of bleeding, it is also appropriate to add a medication like IVIG up front in addition to the steroids. The general guidance that we talked about was that with regards to monitoring for treatment response, you want to see the platelets technically going above 20,000, ideally like closer to that 30,000 range, at least double from the baseline prior to them safely leaving the hospital. And really, at the time of discharge, you really need to come up with a good discharge plan that involves outpatient follow-up, because although a subset of patients will go into a remission after just steroids plus minus IVIG alone, a large subset may require additional therapies or longer courses of steroids, and you don't want, to put your patients in a situation where they're a danger to themselves. And then lastly, again, this is not a one-size-fits-all disease. You really have to individualize your approach to each patient, thinking about their comorbid conditions, thinking about logistics of getting to lab appointments, etc., before you send anybody anywhere. So really just take your time, talk to your patient, make sure you have a good plan in place before they go anywhere.
Ronak, I thought that was excellent. And, what I'll say is that when you have these patients, you gave them a course of steroids, maybe you try an alternative steroid course. Again, we'll talk about this in our next episode. If it's not working, always think about a secondary ITP. I'll always remember that. It's not always just, oh yeah, the steroids, they should work. It's a diagnosis of exclusion. You might be missing something. So I thought this was a great episode. Any other thoughts from you guys?
No, that does it. This was awesome.
Yeah, that's it for me. All right, guys. So then until next time, we'll see you all later.
See you later.
Peace.
This podcast was edited by Resonate Recordings.